Today's emergency departments can often feel like a war zone. The stakes are high, the resources are limited, and the challenges are unpredictable. These on-the-ground realities are not likely to change anytime soon. So what can we learn from military mindset to rise to the occasion and lead departments in these dire circumstances? Dr. Trevor Jain is currently Director of Paramedicine at UPEI. He earned his MD from Dalhousie University before completing a master's and a PhD in disaster medicine. He is also a lieutenant colonel in the Canadian Armed Forces with multiple combat and humanitarian deployments. His talk today will explore the cultural habits that allow military teams to perform their best when conditions are at their worst, and how these habits translate to a modern emergency department room team. Please join me in welcoming Dr. Trevor Jain.
Hello, everybody hear me okay? It's so fantastic to be connecting with my CAEP family. I see lots of mentors that mentored me, whether I wanted to or not, in emergency medicine, and also meeting residents and medical students. Just a fantastic conference. I learned a long time ago that if Dr. Brittany Alice or Dr. Smerico ask you to do something, you better do it. So when I got the call to do a plenary, I knew I wasn't being volunteered. I was voluntold that I was going to do it. I have no disclosures, no grants. I'm not going to be recommending anything. I want to be clear that this talk is based on my opinion and not the opinion of the Canadian Armed Forces. This is not what I'm going to be talking about. So I'm pretty sure you saw that this person would be walking on stage. For those of us with a little bit of gray hair, we know this is Rambo. Sylvester Stallone did a great movie, what it was like to be in the military, running around the jungle, making antibiotic poultices with leaves and sewing up gunshot wounds with gunpowder and lighting it on fire. We don't do most of that, all right? But before I go on to teach or to share some of the things that I learned, I want you to think about this. 5:40 hours on a bitty February morning. There's heavy blowing snow. A transport bus carrying 18 miners hits another truck on a road. It's 25 kilometers to the point of injury from a community hospital. 300 kilometers from a trauma center. The temperature is minus 27 degrees Celsius. And visual flight rules for any air assets are in effect, which is a good thing. They don't have to fly by instruments. Communications is intermittent only in this part of Canada with VHF. And the people that have responded are first responders, a fire crew, an ALS crew, a BLS crew, and some community first aiders. There are 6 critical casualties: crush injuries, trauma, active hemorrhage, 7 serious casualties, fractures, hypothermia, burns, and 5 minor casualties. I want to share with you 7 things that I think that we can do to force multiply our effect as emergency physicians, nurses, and paramedics and bring more clinical firepower to the healthcare system. Number 1 is the incident command structure. Number 2 is a concept called the walking blood bank. Number 3, how can we build high readiness teams? 4, brief chat about advanced medevac systems. 5, accountability. 6, the concept of a fire team partner, which has been around for 150 years. And 7, what the military gets right about honors and awards. So I have my foot in 2 different environments. I have one foot working with a damage control resuscitation team in Charlottetown, Prince Edward Island. Bracket, we have a fantastic locum program. We are recruiting. Dr. St. Josh, put up your hand. He's my site lead. He said he'd have a parade for anybody that signs on the dotted line. Close bracket. 1 foot, damage control resus with the Queen Elizabeth Hospital in Charlottetown. And then that's the other team that I serve on, the Canadian Medical Emergency Response Team, and it too is a damage control resuscitation team. It consists of an emerge physician or an anesthetist, an ICU nurse, 2 advanced care paramedics. The soldiers carrying those guns are also medical providers, but their primary role, they're infantry soldiers. But they've been trained in TCCC, and I use them on the helicopter as part of my resus team. I would propose that both those teams have similarities and differences. The physiology, priorities, and behaviors are fundamentally similar, even though we wear different uniforms, scrubs versus combats. But I also say there are some key differences. For military, when we do damage control resus, we want to get that gun back in the fight. We want to resuscitate that casualty, see if we can RTB, return them to battle, or if we have to get them out of there to a higher level of care. And we measure success by the survival to the next echelon of care. I would suggest that in the civilian damage control resuscitation environment, we want survival with long-term functional outcome, and success is also measured as hospital survival, morbidity reduction, and quality of life. And because of these differences, we have different risk tolerances, aggressiveness, and decision-making matrix. Number 1, the incident command structure. I am a firm believer that all of us need to do level 100 incident command structure. It is free. It will take you an hour online. Your local EMO, municipality, mayor, city/province has free training for you that you can do online. You just got to send them an email, let them know that you're a first responder, emergency physician, a paramedicine, or a nurse, and they will give you a code and you do this training. It is a fantastic tool to use if you're placed in chaos. If I pick you up from your emerge and put you somewhere where it's chaotic and you have a bunch of people around you, it is a fantastic way to organize things. We do know from the disaster literature, 85%, if you're looking only at mass casualty incidences, can be managed pre-hospital or in the emerge department with only 2 positions required: the incident commander and the operations chief. The operations chief is anything that touches a patient. It's a good model for command. It can coordinate any emergency response, and it can be used for any event. It can be complicated, and it's designed to manage chaos. I like it because of its versatility. 15 years ago, a couple used this structure to plan their wedding. 5 years ago, they used it to plan their divorce. True story. It's very versatile. So I'll give you a practical case where this was used. 2nd of September, 1998, 10:36 at night, Swiss Air 111 was flying a run line, a curved line from JFK over to Europe. They had smoke in the cockpit, and they subsequently crashed off the coast of Peggy's Cove. I was seconded by the military to arrive at Hangar B in Shearwater with the mission: you need to build a forensic morgue and have it up and running as fast as possible. And we did this in a team environment. Now picture walking into this room with 7 or 8 different organizations: EMO, justice, nurses, doctors, rad techs, paramedics, legal, and you're not organized. What tool could you use? The incident command structure. We arrived at the hangar at midnight, an hour and a half after the aircraft went down, and within an hour and a half, we sat down, we whiteboarded, and we stood up an incident command structure, verified it with legal, and we were good to go. Remember I said at 10:36 at night on the 2nd of September, 1998, the plane went down? 10:30 on the 3rd of September, we had done our first forensic autopsy. And that's the picture of a forensic morgue, and those plans and that incident command structure is now parked with the Minister of Public Safety on a shelf. God forbid if it happens again, this is the structure that's going to be used moving forward. That was number 1. Remember, incident command structure if you're placed in a situation that is chaotic. Number 2, the walking blood bank. Who here has aware of the walking blood bank? A show of hands. Awesome. So the terminology is changing. We're getting away from the term walking blood banks because we should not be banking this resource. The term that we like to use, emergency blood collection, but I'm going to use them interchangeably. And what a walking blood bank is, I'm the incubator for pints of blood. When we deploy to austere conditions with operational constraints, and I would propose that the Great White North in Canada is austere conditions. I was amazed at talking at some of the nurses, residents, and physicians that have gone up north and heard about their experiences. They are working in an austere condition. We are an incubator of blood. And how we implement this is, for a major operation overseas, the staff that is identified, we are typed, we are crossed, we do a testing for infectious disease, and then we deploy. If we have chewed through our component blood and we need more blood, we activate the walking blood bank. People that are pre-designated line up, and within 1 hour, I have whole blood going into that patient with more pints coming. I don't recommend being like Dr. Abbott with the mandatory pit photo that I have to put in. But yeah, he was donating O-neg while he was working. I don't recommend that you actually do that. CMPA might have her. So this is why we like it for combat operations, but I propose that you can use it for remote care, right? We have logistical constraints with blood. You need a good cold chain. It's difficult to disperse. Maritime environment, operational environment, austere conditions. If you have a mass cache, you're going to chew through your blood products. And prolonged field care. We do know with the recent conflict in Europe, the one and done and calling for medevac to get helicopters there within 25 minutes, that's over. We do know now that we have to keep casualties, God forbid if something happens, for 24 to 36 hours in place. What are we going to do if we have no blood? This is a great resource, and I propose for those of us that work in austere conditions in Canada, every institution, every rural emerge, every hospital, we should be putting pressure and working with CBS to make this happen. Number 3, building high readiness teams. On the right, you're going to see some acronyms. Those are healthcare providers. A critical care nursing officer is our ICU nurse. RNs, administrators, paramedics, combat medics, and medical officers. We all have different scopes and roles with regards to giving health care, but we share common courses that we all do together. We all go for this team on CERI. It's a classified course. It's escape and evasion. It's not the most favorite course to do, but we all do it. We do a land survival course, 10 days. 6 days to learn how to live on the land, 4 days solo phase, no food, no water. And they pick you up at the end of 4 days. But each of us do it. The doc, the nurse, the paramedic. Sea survival, weapons training, physical fitness test, a force test we call it. And then there's a selection process. Then we do cloth model exercises and glasshouse training. What is a cloth model or a tabletop? And I hear this interchangeably all the time in systems. And I want to clarify from a disaster medicine perspective. The tabletop is when you have policy and you're sitting around a table and you walk through the policy, you'll troubleshoot it, give it your sustains or your improvements. But a cloth model is actually game pieces on a board where your bedside folks or the people in charge that can push buttons and throw levers can move pieces on a board. This is my department at the Queen Elizabeth Hospital. Exactly laid out the way it is. That was taken from a PDF given to graphic folks at our university, printed out on banner material. We went to a craft store, got some game pieces, and using a computer program that printed off business cards, we printed off casualties, nurses, doctors, medics, ward clerks, everything. And it's been adopted by our facility where our chief gets all the new docs and all the new nurses have to run through this cloth model exercise on our Code Orange plan. $200 or less, you can rehearse your Code Orange plan. Standard operating procedures for us don't exist unless they're rehearsed. Glass house training. So Glass House is an exact replica of the facility that we get deployed to the dimensions, to the equipment that we grab right off the shelf. You'll see that there are half walls there. And that's because when we're fed casualties, the evaluators surround those walls and they are designated which individual they're going to critique. And it's brutal. And they watch you while you do your high fidelity simulation, resuscitation, and critique you. What's the advantage of this? Of doing the exact dimensions with the exact equipment that I'm going to use. So this was in Ontario at a warehouse that we practiced. Then lo and behold, in northern Iraq, there was a mass casualty incident where Navy SEALs got involved in combat, and we were receiving multiple Navy SEALs, and our job was to resuscitate them. When we reached for that bag valve mask, or when we went to get the blood, or any of our tools to resuscitate, they were in that exact spot, the same dimension, the same company, the same brand, where it was when we did the Glass House training. And that really force multiplied our effect. In the picture, there's 2 resuscitation teams, 1 on each stretcher. They're just landing with the SEALs outside the door. The incident commander is the doc with the yellow hat. You see the German surgical team on the right, all gowned up, ready to go. You see X-ray in the foreground, and the lab staff's on the left, ready to crack the blood, getting it ready for our level 1 infusers. And that picture is taken from the entrance of the OR, literally 3 meters away. Number 4, advanced medical medevac systems. One of the frustrations that I find, or one of the curiosities, I'll rephrase that, one of the curiosities I have on the civilian system is that there's not one standard medevac process coast to coast to coast. If I told any armed forces people in this room, or the 77,000 that are currently serving, how would you medevac that soldier that just broke his leg and needs to get out of there? They would say, sir, we need a 9-liner. So we have one process that has been socialized throughout the entire forces called a 9-liner. It's called a 9-liner because there's 9 lines of information. I think there was 5 committees that went into it to name it, so tough crowd. So it's a 9-liner. Any soldier, any medic, any nurse, any medical officer can activate our patient movement center and start to move assets by giving the first 5 lines of information. They just need to give 5 lines. And while the helicopter, the boat, the truck, the ambulance, whatever vehicle we have spools up, they get the other 4 pieces of information. While we're in the air, so we get first 5 lines, we're running to our helicopter, we're getting gowned up, we're getting all our gear, we're putting our weapons in the rack, we're getting ready to go. We get the other pieces of information, and we get a mist. And as we go down the list of the casualties that we're about to pick up at the point of injury, we get mechanisms of medical complaint, the injury or illness, signs and symptoms, and treatments that have been done. So I'm just going to need some sound for this.
I have 3 patients for you. Your most critical patient is this patient here. All patients were part of an IED explosion. The 24-year-old German soldier, IED explosion, bilateral amputations, pelvic fracture, abdomen, chest, heart, good by point of care ultrasound. We retrieved 3 units of RBCs, 3 units of plasma, got eripenem 1 gram, got calcium chloride, got TXA 2 grams, got ketamine 5 milligrams. He's volume depleted, loss of blood, tourniquets are in place. Do you have any questions for me?
No, it's good.
So that was an example of a handover. So our doctrine for CMERD, we can take 7 patients at once. Our standard is that 3 of the critical patients have damage control resus complete, including intubation, blood administration, rolled, chest decompression, bones set in place, IV started, pain control, blood going, and as well as being intubated. That's the standard. We have 25 minutes. So when we train our docs and our teams to do that in their team, that is by the end of their 3 weeks of training them to be on this team, that is the expectation. And the reason is that at the end of 25 minutes, that in ICU doc that's just taking that patient over, they're going right to surgery. I do want to give a shout out to our rural emergency medicine physicians. Meet Dr. Rob Warren on the right. And Dr. Warren is a Canadian hero. He's an emerge doc that was doing some shifts in Truro. He was in Mali on the Canadian Medical Emergency Response Team, which is our Chinook helicopter, which I just told you can carry 7 patients at once, 3 critical. And they got the call that there was an IED strike on a bus, and there were 14 casualties. And they were a bit delayed getting there due to some geopolitical reasons, but they got there. He made the decision to unclip and dismounted his entire medical team, triaged them on the ground, started some basic treatment while gunships were circling above, protecting them. And then instead of taking 7, he airlifted 12 in one lift, including below knee amputations, this little girl here, and multiple other injuries. And I would say that his training as a rural emerge doc, making those critical decisions in an austere environment and limited resources, really worked for him. Number 5, accountability. As an emerge doc, I'm accountable. I'm accountable to my chief if I'm not performing. I'm accountable if I'm ordering too many tests. I'm accountable to the college. I'm accountable to the hospital. I'm accountable to the nurses. I'm not worried about physician accountability. I am concerned about accountability with regards to management and administration. And we have 2 examples of that. We have a lawyer on the West Coast, Dr. Caitlin Stockton, who was harassed and bullied by Fraser Health. That should never have happened. She took them to task and they settled. On the East Coast, 2 CEOs ago just arbitrarily gave the top 5 executives a 30% raise with no process, no accountability. In the military, everybody is accountable regardless of rank. I get a quarterly evaluation every quarter. That's why it's called a quarterly evaluation. I see what I did. Ah, you're brilliant, Trevor, great. And yearly, we get a formal evaluation that's 6 pages with different characteristics. Everybody, the medical officer, the nurse, the paramedic, the administrator, the commanding officer, the brigade commander. The brigade commander reports to the brigadier, has a 2-star, give his evaluation, the 3-star to the 2-star, 4-star to the 3-star, the CDS to the deputy. Everybody is evaluated, and there's certain ethos and common criteria that we have to meet. We need that in the Canadian healthcare system. We need accountability that is transparent, and we have a lot of physician accountability. That's great. Let's spread that joy and wealth to other parts of the system and have that same high level of accountability. Number 6, it was interesting to see some of the talks today, and this is starting to bubble up in the civilian world, having a fire team partner. And my last 2 points, number 6 and number 7, is really where I think we could help our own mental health and our own resilience. The K9 unit that you see on the right, those 2 soldiers with their dog, I guarantee you they know each other just as well as the spouse knows them. They have a professional intimacy that is difficult to delineate or talk. And in the Army, in our smallest unit, the fire team, we have that. That is the person that has your back professionally, that elevates you, that nominates you for an award, that's got you on your bad day, that stopped by and gave you a coffee, and also keeps you humble. We need that in emergency medicine. I am blessed that I have a fire team partner in my emerge department, and we share everything. He has my back at a meeting if I feel that it's not going well. If I feel there's bullying or harassment, they got your back, and I really believe that we need, in emergency medicine, we need organically to find our fire team partner. Some don't like that term. I've been playing with the term co-pilot. And if you notice on any movies that show airplanes flying, a lot of those big aircraft, the co-pilot and the captain, when they're cleared for takeoff on runway 27 out of Winnipeg, both they're holding hands on the throttles to push it forward. So they know what each other is doing, right? So they know what each other is doing. And even the inputs on the flight control systems, unless it's a Boeing, inputs on the flight control systems, they know what each other's doing. If the co-pilot's flying, the pilot knows the inputs of that column. That's why we need a fire team partner. Number 7, honors and awards. The military does a solid job of giving honors and awards to people that do amazing things. And I think CAEP does a solid job of doing honors and awards at a national level and a regional level. But we can do things as emerge docs locally in our own emerge department. This is the COVID Warrior Coin Award. So in March of 2020, I noticed that there was only 3 people that were getting a lot of accolades in our province. And rightly so. They deserved those accolades. But you know who wasn't getting accolades? Was the Island Waste Management Company truck driver getting the garbage in the subdivisions. The cashier at the local grocery store that checked on the elderly to make sure they got their groceries. The retired pharmacy driver who was driving around all over PEI to get medications to the elderly, or the vice principal of the local high school that put the curriculum online. So I came up with this idea called the COVID Warrior Coin Award. In the military, we have challenge coins. You haul them out of your pocket. If you have yours and I have mine, great, but if you don't, you owe me a drink. It's called a challenge coin. So I made this coin, and it said Team of Teams with a Spartan helmet on it. I made a certificate just on my computer, and I started handing them out around the island, and it started to take off. The Premier's office called me and said, "Hey, Jane, what are you doing with this COVID Warrior coin? Like, can we get involved?" 1,000%, just costs you money, right? And so the Premier's office got involved, and then my fire team partner said this, "Trevor, do you really think Islanders want to get this award from you, or would they like to get it from the Lieutenant Governor?" I said, "That's a brilliant idea." I approached her on her, and she said, "I would love to take this on," and it became a provincial award, and Islanders that live in our most rural areas were getting recognized, and they were going to Government House to meet the Lieutenant Governor in a formal ceremony with their families, some who've never been in that building. That gave us leverage as an emerge department because it created a relationship with the public. And I think we can do more of that for different things that we want to advocate for. So going back to our case, that local hospital, it had an incident command structure. It had strike teams. They stood up 2 strike teams to respond to casualties. They had rehearsed with a cloth model exercise a bunch of new staff, so they all knew their plan intimately. They had advanced medic systems that they only had to give 5 lines of information to start getting medical assets to come and transport patients. And they only had 4 units of blood, but they activated their walking blood bank, and fresh whole blood started to show up within 1 hour. ICS prevented chaos. Advanced medical systems got the resources they needed. Because the emerge did things outside the emerge that were non-medical and hard things, they knew each other's strengths and weaknesses. They activated their walking blood bank, and they created an honors and award system who gave a paramedic an award, who commanded the scene and was got in front of the Lieutenant Governor. I hope that you can take these 7 things that are going to result in stronger teams for you, more positive workplace environment, and I also propose that it will give better care. I want to thank Mary, Tom, and Garcia, my teammates on CMERT, for keeping me honest and the incredible work that they do every day. Thanks for listening.
Thank you, Dr. Jain. All right, we've got some time for questions. There's microphones out in the back of the rooms. Please come up and come up with your questions. I'll start us off. So, Dr. Jain, you have experience working in both a military capacity and in civilian emergency departments. A lot of the time, the chain of command, or there is a chain of command in the military, but it's much less formal when you're managing a team of nurses. How do you set up how do you inspire confidence when there's less of a hierarchy there? Do you have any tips for inspiring confidence in your coworkers when you're the leader, when there's a tension about breaking down hierarchy in the emergency department?
Yeah, so that's a misnomer in the military and healthcare. We have a very flattened hierarchy. So although I'm a light colonel on this team, Garcia calls me bucket lips, you know? And he's a corporal, right? So we're on first name basis. It's a very flattened hierarchy, and we know each other's skill set. So how many of you can actually start a bloodline? How many of you can go draw a med or get into your PICSA system? How many of you know how to go get and work with the lab? We are trained that way. My nurse knows POCUS. My medic knows how to do a surgical crike and also an intubation. So flattening that hierarchy with procedures and skill set instills confidence because you developed the key thing that you need on high readiness teams, which is trust.
Trust. Amazing. Thank you. Looks like we have no other questions. I do have a question for you, Dr. Jain. Did you get your ticket to Docs That Rock tonight?
Absolutely, because I heard Dr. Fraser Mackay is making a guest appearance, maybe, so I better see that cape on him tonight.
Amazing, amazing. All right, if you need to know anything about Winnipeg, it's that Winnipeg rocks. So come out today. Hope to see you all there. Thank you, Dr. Jain.
Thank you.
Thanks.